Hello, Dr. Dorsey, and to the rest of my class, I'm going to be presenting a case on fibromyalgia. Some background about the disease. It is defined as a chronic, widespread musculoskeletal pain with fatigue, includes cognitive disturbance and sleep disturbances, is categorized by persistent pain that affects both sides of the body, and is often accompanied by tenderness in specific areas known as tender points. The pathophysiology of fibromyalgia, it is complex and involves multifactorial neurobiological dysfunction with pain sensitivity due to CNS abnormalities, disrupted neurotransmitter balance, stress system dysregulation, and neuroinflammation. And specifically when it comes to the neurotransmitter imbalances, there's a decrease in serotonin, norepinephrine, dopamine, and an increase in glutamate. And right here, I inserted an image that kind of summarizes the pathophysiology of fibromyalgia. The prevalence of fibromyalgia, 2% of U.S. adults are affected, with 80 to 90% of those being women. And the biggest age group for it is between the ages of 30 to 60 years old. It has, when it comes to the lives of those affected with it, they're affected with their quality of life as far as the pain and the fatigue and the cognitive impairment, and this impacts their day-to-day function greatly. Economically, the treatment for it can be very costly, and then there's a loss in productivity due to individuals possibly not being able to work or work as much. For my patient that I seen in clinical with fibromyalgia, she presented with her chief complaint of, I have pain all over my body for months and I'm always tired. This was a 55-year-old white female, and she presented with a 14-month history of persistent, widespread, generalized pain and fatigue. The pain developed without a known precipitating cause and progressively worsened over the past year. The pain reaches a 9 out of 10 on the pain scale. The pain was bilateral, involving the cervical region, her shoulders, upper and lower back, hips, thighs, and knees. She reported that her symptoms were exacerbated by prolonged activity, cold weather, included poor sleep quality and stress. She said the symptoms were relieved by warm baths, gentle stretching, and periods of rest. She denied any recent trauma, febrile illness, weight loss. She had not noticed any muscle weakness, but reported intermittent tension, headaches, and occasional palpitations during pain flares. She had tried using NSAIDs, but had minimal relief. And then she also discontinued using them due to GI upset. She had not been seen for this prior anywhere else. She said her mood was stable, but she did report mild anxiety, which was evident during her exam. She denied any suicide ideation or psychiatric hospitalizations. And here's some of her, excuse me, let me go back. And some of her past medical history here. And here's the review of systems. She, of course, is positive for chronic fatigue and weakness, generalized weakness. She did not fever, chills, and any weight loss, no skin changes, no abnormalities with her eyes, her ears, her nose or throat, but she did report the headaches and just again some occasional palpitations during her periods of pain. And here is the rest of her review of systems. Again, she's a positive for the bilateral muscle weakness. She reports what is described, she reports what is considered to be fibro fog, which is defined as the decreased concentration, the slow processing, and memory lapsing. Her vital signs were within normal limits. She did appear anxious again, and she had 11 out of 18 tender points during the physical examination of her muscles and her joints. And so the labs that were obtained during this visit were CBC, CNP, TSH, ESR, and CRP, which all came to be normal. An ANA and an RF were also negative. When it came to the American College of Rheumatology criteria, her WPI was a 14 and her symptom severity scale was an 8, which meets the criteria for fibromyalgia diagnosis. And so with everything that was reviewed, it came out to be that the likely diagnosis for this patient was fibromyalgia, and our differential diagnosis that we ruled out was hyperthyroidism, rheumatoid arthritis, and polymyalgia. When it comes to treatment goals for fibromyalgia is to, of course, reduce the pain, improve function and quality of life. We educated this patient regarding this disease, encouraged exercise 2 to 3 times a week. We gave her a rheumatology, PT, and behavioral health referral, and we encourage good sleeping hygiene. We started her on 30 milligrams of duloxetine daily for 2 weeks, and depending on how she would tolerate it, we told her that the dose would be increased to 60 milligrams daily, and we would be giving her a phone call just to assess her tolerance of the medication. And this treatment was, oh, I'm sorry, and her follow-up would be in 6 weeks. This treatment was based on the American College of Rheumatology and the European League Against Rheumatism guidelines. And here are my references. And that is all I have. Thank you.